Let's go ahead and get started. Again, welcome to Bay Medical Center Sacred Heart this morning. This is a very exciting day for us here at the hospital. Exciting in that we want to formally make an announcement to our community by way of a service that the hospital is offering. It's also exciting because today for us kicks off Hospital Week, a week when we can honor and show our appreciation to our many employees here at the hospital. We also recognize National Nurses Week during this week as well. And in fact, we just came from a celebration. We do what we call a Daisy Award celebration, where we honor excellence in nursing. And we were able to do just that this morning in honoring a nurse specifically for her efforts here at the hospital. So the week's off to a great start. And in that light, I want to, if I could, make a few comments this morning on behalf of the hospital, on behalf of our board at the hospital, and on behalf of our medical staff and our many employees. And it's an announcement regarding new technology that we have implemented here at the facility. And when I say we, I do mean we. This has been truly a collaborative effort, bringing together many, many departments within the facility. But certainly I must also say that the collaborative effort was the vision of many of the folks you see here in front of you, our cardiac surgeons as well as our cardiologists. What is the procedure? The procedure, as we call it, TAVR, T-A-V-R, Trans-Aortic Valve Replacement. It's a procedure that is typically found in large tertiary teaching hospitals. But I'm very proud to say it's also a procedure that can be done very safely, very well, right here at Bay Medical Center Sacred Heart in Bay County, Florida. It's truly an investment on behalf of our community that we're able to offer this service. I'd like to thank the team who's worked so diligently to put this program together. It's truly been a team effort where many teams came together working to implement this service in such an excellent way. The team consisted of our cardiovascular surgeons and our cardiologists, as well as the many highly trained technical folks that we have employed here at the hospital. So today we have in front of you our cardiologists, or a few of our cardiologists, I should say, and cardiothoracic surgeons, and they're here to tell you more about this procedure. And we also have in the room a very special treat. We have two of our patients, former patients, who decided they would share this day with us as well. Mr. Morris Denman, thank you for being here. Ms. Nancy Vanderberg, appreciate you folks being here today. You'll have an opportunity to hear from them in just a moment. So that being said, your team of physicians, your panel today that we would like to have speak to you, Dr. Greg England, cardiothoracic surgery, Dr. Amir Hagi, interventional cardiologist, Dr. Samir Patel, interventional cardiologist, and Dr. Lynn Sito, cardiothoracic surgeon. So that being said, I'd like to turn it over to our panel, and I'm not sure who is going to speak first, but maybe Dr. Patel?
Yeah.
Please, take it away.
So please bear with me, I just reviewed these slides not too long ago. But I'm taxed with the responsibility of talking about aortic stenosis. So before I talk about aortic stenosis, I wanted to thank Steve for bringing this technology, Steve and the team for bringing this technology over to Bay Medical Center. We've been talking about this for a few years, and our team here has been very excited about this relatively new way to treat aortic valve stenosis or minimally invasively. And we've been talking about this for about 3 to 4 years. And when the new administration came on board, that's when this really took hold, and it's been a reality since February 1st. And there's a lot of preparation that went into it prior to that. So we'll talk about what the disease we're treating. It's called aortic valve stenosis. So when I talk to patients about the heart, I usually tell them there's 4 chambers of the heart, just like a house. You have a house with 4 rooms and 4 doorways. And the main doorway of the house is the front door. So your aortic valve is one of 4 valves that is the front door to your heart, that allows the blood from the heart to reject out into the body with each heartbeat. And these valves have 3 leaflets. And these leaflets open and close in one direction several thousand times a day for however many years the patient is living. And if you can imagine a door that's been doing this, opening and closing several thousand times a day, after a while it gets a little cricky or rusty. So that's what happens with aortic valve stenosis. A healthy aortic valve, you have 3 leaflets. Over time, those leaflets can get calcified or degenerated. And what happens is, instead of opening up nicely, there's a restriction in that opening. When you have a restriction in that opening, the blood flow is not able to inject to the heart as efficiently. And the most common symptoms that patients would experience are shortness of breath, chest pains, and once it gets to be very severe, they can even faint. This limiting blood flow going to the brain. It primarily affects adults as they get older. Their 6th, 7th, and 8th decades of life. Seen about 3% of adults over the age of 65. And we talked about some of the symptoms already as far as shortness of breath, chest pain, and fainting, fatigue, dizziness are also common associated symptoms. When we diagnose aortic stenosis, the first thing we do is listen to the patient about their symptoms, and then we also listen to the patient with the stethoscope. And we usually hear a murmur. That's turbulence or restriction of flow exiting the aortic valve. Once we have a suspicion of significant aortic stenosis, we'll do an ultrasound of the heart, and that'll give us exact measurements and gradients across that valve and how tight that valve is. We measure the area by square centimeters. And anything below 1.0 square centimeters is considered severe. We've had patients as low as 0.2 square centimeters that we did recently. Once we do the echo, the next step is to take them to the cath lab and do a heart catheterization. We also want to assess for any corneal lesions that may be contributing to their symptoms, or they also need to be treated prior to the TAVR procedure. Now, historically, aortic valve stenosis have been treated surgically. I'll let Greg or Lynn's going to talk about that in a little bit. So this transcatheter valve has been approved for patients that are considered either high risk for surgery or intermediate risk for surgery, most recently. So these are patients that otherwise would not have had any treatment with surgery. They're too high risk. These patients historically have been just managed medically, and as I'll show you in a little bit, they haven't done too well. So what we look for is the onset of symptoms when they have aortic stenosis. So this is age down here. So right around the 6th, 7th decades of life, when you start developing symptoms of chest pain or angina, syncope is another word for fainting, and heart failure, shortness of breath, patients don't tend to do very well once they start developing symptoms. As you can see, once they start developing chest pain, their average survival is 4 more years. So if they're 65 with severe aortic stenosis, half of them will be dead in 4 years if that valve is not replaced. That time frame lessens as the symptoms get more severe. Heart failure, 2 years, fainting, 3 years. So it's a very progressive disease. And that just goes to show here, about 50% of them at 2 years are not alive if these valves are not treated. I'm going to turn it over to one of our surgeons to talk to you about different valve techniques.
So once a patient becomes symptomatic and has developed severe aortic stenosis, that's an indication for surgery, which traditionally has been required open heart surgery that many people are familiar with. They take the patient out of the room, put them to sleep under general anesthesia, open the chest up, hook the patient up to the heart-lung machine, and arrest the heart for about an hour and a half. We go in, we cut out the bad valve, and sew in a new valve, and then reverse that whole process. And the patient ends up being in the hospital typically about a week. Full recovery is usually 2 months plus. So it's a big operation, and it's done very commonly here and elsewhere. But it's a lot to go through. The problem about severe aortic stenosis, though, is that once the patients become symptomatic, we give medications that will sometimes help relieve the symptoms, but the problem is that it doesn't relieve the anatomic abnormality with the valve. The valve is still severely narrowed and continues to get worse. Why you see that terrible survival curve that Dr. Patel was showing. So without replacing the valve, the long-term prognosis for these patients is very bad. However, if we are able to successfully replace the valve, the patient will do quite well. Problem is, it's a very invasive procedure until now. These are the valves that typically are used for surgical valve replacement. The freestyle valve we use occasionally. Second one over, the Hancock 2 valve, is a tissue valve or a bioprosthetic valve. For the last 15, 20 years here at Bay Medical Center, that's the one that's used most commonly. The fourth one on the end is a mechanical valve, similar to the one we use here. So these are the valves we open up the patient, cut out the bad valve, sew this in with sutures, and then close things back up. An operation that typically takes 4+ hours. And once you successfully do that, the patients, once they get out to six months post-operatively, then their survival, instead of being very bad, as we saw on the other slide, matches that of comparable, similar age patients. So a 65-year-old that gets 6 months out from their successful aortic valve replacement, their long-term prognosis now is 18 years as opposed to 2 or 3 years. So a dramatic difference. And this is a slide, a graph that shows that. The top line is the survival on patients that have had successful aortic valve replacement going out to 5 years. So it's better than 80%. As compared to patients that don't get surgery with severe aortic stenosis, at 2 years, somewhere in the ballpark of 20% of those people are alive. That's a dramatic difference. This is one of the most dramatic differences you'll see in anything we do in cardiac surgery and other areas of medicine in terms of what we can do to intervene and the outcomes from it. And this is just to give you some idea of the volume of things we're talking about. When we assess patients that with severe aortic stenosis for possible valve replacement, they really fall into 3 groups. There's low operative risk, intermediate risk, high risk. And then there's even some that are so bad off that the operative risk is prohibitively high. And historically, we would give patients the best medical therapy and comfort measures, but they wouldn't do well. When transcatheter aortic valve replacement first became available, it was limited to these people and these people. Now it's becoming more and more used in the intermediate risk. But to put this in perspective, we're talking about 120,000 people in the United States a year develop severe symptomatic aortic stenosis. It's somewhere in the ballpark of 40%, give or take, of those patients are high risk or inoperable patients prior to transcatheter aortic valve placement. That's more than a professional baseball stadium full of people every year. That their prognosis is very bad, 2 years, 3 years survival. But with successful valve replacement, we can make it much better. Next.
So, all right, what you've heard so far and where we're at in this presentation is we have to give you some background just because we're assuming that a lot of the people don't understand the pump. So you've heard Dr. Patel speak very eloquently about the front door to the rest of the body. And then you heard Dr. England talk about how has this been treated historically. And actually, more to the point, how about those that weren't treated historically? So that 30–40% of people were saying, okay, medical therapy. You just heard medical therapy basically means you're going to die in 2 years. So those patients were either being sent to faraway places like Atlanta or Jacksonville to get it done at a university center, or if they had a support system and the ability to get there, or they're just staying here and being given medical therapy, which means not much. So now we have this opportunity, and that's what we're here to speak about. We're building it up, and in the last stage of this, we're going to talk about the team that it takes to do that. But in this part, we're going to show you a little bit about the actual transcatheter aortic valve replacement itself, and I brought my little props because that will help you to see it better. And here's the device. So historically, what Dr. England was referring to is sternotomy. It means that they open the chest through the sternum, and they're actually getting into the heart to replace the calcified and dysfunctional valve. Now what we've got is this new device, which is just this big. I mean, it comes in several sizes, all of this plus minus a couple millimeters. And it's implanted through, Dr. Patel has here in his hand, through a delivery system that's only that big. So as you can imagine, now we have the opportunity, instead of cracking open someone's chest, to do this through the femoral axis, and we've done multiple cases through subclavian axis as well, where we don't have to
open the patient, but we're using minimally invasive approach. And that really, as you could immediately envision, helps to the patients recover. So for example, if they have really bad lungs, rather than going on some long procedure with the extra stress on their body, this could be done through the groin. And if you think about it from the patient's perspective, they're coming over to the lab, they're in there for a couple hours usually. It could be as short as an hour and a half, it could be a few hours max, but they've got a new valve in there without having to go through all that invasive approach. Much less invasive. Here's how the device is. It has a nitinol frame, as you can see here, and in there is the valve itself. And there's a little skirt here that's at the base here that helps to prevent leaking of the valve. It's actually in that delivery device that Dr. Patel was holding up, and it's delivered into the position of the aortic valve. Some people ask me, do you take out the old valve? But we don't. Actually, this goes right into that position. Here are some of the access approaches. They can do transfemoral, which is what we've done in most of our cases to date. But we've also done several patients subclavian based on the anatomy being too limited here in the iliacs. And there's direct aortic approach possibility. This is how it looks like when we deploy the valve. We use fluoroscopic guidance, and what that is in the cath lab. We have the ability to watch under fluoroscopy as we cross the aortic valve, and I think we have an animation here coming up in a moment that'll show that. And then we actually have, and it's truly a team event, unlike anything I've ever worked in or any of us has ever worked in medicine. You've got echo people watching with the transesophageal echo probe. You've got 2 sets of hands and sometimes 3 sets of hands on the device itself. Somebody's actually positioning it and somebody else is actually deploying it, and every millimeter counts because you want it to be placed just right to relieve the stenosis, but also to avoid excessive leaking or dislodging of the device. So you're watching it very carefully, and you have multiple ways of making sure that it's positioned just right as you open the new valve in that position. And so once it's open, you can see then that the obstruction has been taken care of in the sense that now you have full ability of that front door to allow the blood to the brain, to the body, so the patient no longer feels as short of breath, or they're not as dizzy or passing out or having the chest pain that they were before the procedure. And we do have, I believe now, an animation. This is my first time seeing this particular animation. It doesn't. Okay, so here we can talk about that. You have a very calcified aortic valve. The front door is not opening well. And so that's limiting. Imagine that, the pressure that your heart has to generate to get this blood up and out to your brain and body. So sometimes we get patients with up to 100 millimeter difference in their heart compared to what their body's seeing. And then you have the transcatheter delivery system coming across that aortic valve to position this device so it can be deployed just right in the aortic position here. And then you can see once it's in, now you've got a new functioning valve that opens well. And in this thing, it's 100% perfect. But actually, in reality, too, we see that we get very minimal gradients, and it's been wonderful in each of the cases that we've experienced here. I think one of the kind of big picture, and I don't know if this is going to keep going or not, but one of the big picture things is that we're helping people and able to provide this in a way that historically they would have to travel far to get that, but also it's something that as a medical community, we're extending lives by this. It's quality of life and quantity of life. These are patients that otherwise would be facing mortality within a couple of years on average. And just if anyone wants to look at that later, or the media wants to get a picture of it later, they do have that, like an implanted one in this model heart for later. Okay, I think that's the end of my section. Oh, one other thing to comment on is the outcome. So how did the patients do after TAVR? The great news is that it's showing similar results as the open heart surgery. So what they did was they compared high-risk patients and now intermediate risk patients in terms of getting the percutaneous approach, the transcatheter aortic valve replacement to open surgical procedures, and it's similar in terms of survival, major stroke rates, valve leakage, and hemodynamic performance. And it's much better in terms of the patient's recovery and able to withstand the surgery. All right. And so for the last part, we're going to transition here into the program requirements. Dr. Cito is going to speak about the team.
So, how hard could that be? It looks pretty easy on the video, right? Yeah. Let's see. So, I'm here to talk about behind the scenes. One of the reasons why I came to Bay Medical, in addition to joining my two partners, was because Bay Medical has always been on the cutting edge of getting technology into the community. Before I got here, Dr. Finney and Dr. England had started a robotic program. And this TAVR program has actually been in the works now. We've been working on it for 4 years. In cardiac surgery, we always talk about how we can have the least invasive approach for a patient, the least amount of trauma. And there are two different ways of looking at that. First is the size of the incision. And then the second is whether or not we use the heart-lung bypass machine. So the size of the incision can be from the top of your collarbone here all the way down almost to your belly button, cracking the breastbone, maximally invasive. And then various step downs to a small incision here, maybe a small incision on the side. But that's about as good as we got with our incisions up until robotics, where we can do valve surgery with 5 tiny little incisions on the side. But that's still, all of those procedures still need to use the heart-lung bypass machine, which up until now has been a necessary evil. I think the real beauty of TAVR in selected patients is that we eliminate virtually the incision, and we're eliminating the effects on the body of the heart-lung bypass machine, which is a tremendous benefit, as you'll see soon. So we didn't just sort of think this up. We have societies and, of course, the government that very rigidly study these procedures, what the outcomes are, and have guidelines for us. So one of the things that is really different today, training, versus when I started medical school in the 80s and the 90s, was the concept of a heart valve team. And all you need to know about that is look around. Our team is in here, and this is only a fraction of the team. If we had all the team in here, we'd have to have it in the auditorium. So the concept of having the patient be seen by multiple disciplines, all looking at them from different viewpoints to have the best possible outcome for the patient, regardless of whether it's a surgical aortic valve, a percutaneous aortic valve. Sometimes, not to get too complicated, Dr. Hagihat or Dr. Patel will just use a balloon to break open that valve so we can get the patient in a better physiology and more prepared. So there are lots of different treatment options that up until the last 5 or 10 years were from different disciplines looking at it independently. And sometimes not here in this institution, but in some institutions it can become a tug of war. So this is from the American Heart Association and the American College of Cardiology, and that just outlines that you want to have this type of procedure done in a place that can do everything and be prepared for every eventual, whatever happens, we're ready for it. And this talks about the old paradigm where you had the surgeons, and then you had the cardiologists, and then you had interventionalists, and then you had the medical cardiologists and the family practice doctors, and everybody's looking at it from a different way. And they didn't always agree on how to treat patients. Here, we were blessed in that before we even considered doing TAVR clinic, we already had an excellent working relationship with our colleagues in cardiology and other disciplines here. It's a very cohesive medical community, which really, I think, gave us an edge. So in terms of our team, it includes obviously the cardiologists, the cardiac surgeons. By necessity, these patients all have to be evaluated by 2 cardiac surgeons that say this patient is X% risk. That's mandated by the government. We have imaging specialists, echocardiography, 3D echocardiography that we now have, again, with Bay being, trying to stay ahead of the technology. We have a dedicated cardiac anesthesiologist that looks after the patients while we're playing with our toys and make sure that everything's good. And of course, perfusionists, nurses in the operating room or in the CAS suite, nurses in pre-op, nurses in the ICU like Derek. It's a lot of people looking after these patients. Experience is important, and like I said, you wouldn't want to go somewhere where if something happened, they wouldn't be able to do whatever they needed to do to make things right. And the government has had very rigid criteria, especially since this is a new procedure. And these are some of the requirements. We have to do at least 50 surgical aortic valves, and more than 10 of them have to be high risk. When we say high risk, we're not just saying, you don't look like you're going to do so well. We have a very rigid, systematic approach that we do based on their valve gradients, their age, their comorbidities, and it's equal among all of us. So it's called an STS score. STS stands for Society of Thoracic Surgery. So if I look at a patient, I can figure out the STS score. At risk greater than 8% is considered high. And if Dr. Patel or Dr. Haggy-Hatt or Dr. Finney or Dr. England or whoever does it, they'll get about the same. So it's reproducible. 2 surgeons, and you have to have a robust cardiology practice. They have to be very skilled with catheter skills, with balloon valvuloplasties, so that you're prepared for any contingency. And this is what the government has mandated. You have to have a heart valve clinic. And the unsung hero on this is Josie. She gets in touch with these patients. She's their contact point, their sanity, so to speak. She coordinates the exhaustive workup that these patients have to go through, and then make sure that the 4 of us get all that information and know what to do with it. She holds their hand before, during, and after the procedure, and holds our hand too. And this is a small part of our team. I think we're going to take questions now.
All right, thank you. Thank you all very much. I would be remiss if I didn't also recognize Dr. Reed Finney, who's in the room. Dr. Finney, thank you for your vision and for being a champion in helping to bring this technology, this service, this expertise to Bay County. Thank you for that. We want to open it up for questions, but even before we do that, I thought it might be nice if you could hear from our patients. So I'm going to put them on the spot and see if you would like to come up and say a few words and maybe answer some questions. Mr. Denman, would you like to go first? Well, how about we do ladies first? Ms. Vanderberg, would you like to come up and talk?
I'd be happy to. Okay.
Thank you for doing that. Your doctor has great confidence. Yeah. I know this is unscripted, but if you'd like to just tell the group a little bit about what you experienced and maybe how you're doing today.
Well, I have experienced the miracle of my life, and I'm still here at age 89. I'll be 90 in November. Many people thought I was too old to go through this, but I wanted to have a few more good years in life, and I certainly have gotten them. Thank you to these wonderful, wonderful, talented, skilled people, and all of you, every one of you. I appreciate it so very, very much.
And if I could just have you stand here by me, Mr. Denman, would you like to come up and say a few words as well, and then we'll let the crowd ask you both questions.
If you can't remember my name, I sometimes go by number 7, and I was number
I'm
7. I really appreciate the opportunity to be here today. One of the reasons is I'm constantly meeting people who are involved in this procedure that I never met before. Many of them were in the operating room when we did this. Dr. Hagyhad had been watching my valve deteriorate for some time now. When he began to tell me about the TAVR procedure, I was excited about that. About 19 years ago, Dr. Finney cracked me open and did 3 bypasses, all of which are still open, by the way. And had done that and did not want to do that again. And so then began the process of talking to people, met Josie, talked with Dr. England, which I understand he was the one that actually put that thing in. And Dr. Cito, who was incredibly helpful in helping me understand a lot of what was going to take place. The procedure itself, I had the procedure on Wednesday, went home on the following Tuesday. Took a couple of days off to recuperate. I'm a semi-retired minister. Got out of the hospital on Tuesday, took a couple of days off to rest and recoup, and was back in the pulpit on Sunday. You just can't get any better. And so I appreciate the opportunity.
Thank you.
So at this time, I'd like to just open it up to questions. You might have questions for our patients. You might have questions for our panel. Any questions in the room that you'd like to ask?
I'd like to ask how quickly you noticed that your symptoms improved after the procedure.
I noticed
What were your symptoms before the procedure, and how quickly did they
Before
improve?
my procedure, I was very short of breath. I could not walk very far from the house to the car to the house. That's something that got to me too. I couldn't drive for 2 weeks, but I'm driving again. As soon as
Let us know when you're on the road.
I'm a good driver. So, anyway, after I recovered, right away, I felt better and stronger and could walk. And my family noticed it, and everyone noticed it, and I just had more energy. And I went home 2 days after my procedure. Wow. And it was a wonderful recovery, thanks to everyone. And I feel like a new woman.
How about you?
The same, yeah.
How did you feel?
I had gotten to the point where everything I was going to do in the day, I had to do before 12 o'clock, because about lunchtime I just ran out of gas and I had no energy. I could not do anything physical at all. If I did, I got shortness of breath, chest pain, the whole 9 yards. And so once I got out of the hospital and took a few days to just recuperate, then I got back to my normal schedule and I started doing things. I've got the energy, I don't have the chest pain, I don't have shortness of breath. All of that went away. And it was just, within a week, I was back doing everything I wanted to do. And so I'm very pleased with that whole process.
Other questions? Take a runner.
That first Sunday you were back in the pulpit, was the sermon longer or shorter than that?
Oh, you know, for some folks, it's always too long.
They're the ones that need it most.
Well, you know, sometimes you just go to your default position, take an offer, and you go home.
I have a question about the training to do the procedure. And I know the answer, but I want to ask if you would just share with the team the specialized training you received to be able to do this procedure.
I mean, it was, because you speak to it, but in the first place, you have to have a certain operative volume if you're the surgeon, or if you're the interventionalist, you have to have done a certain number of interventions, including structural heart cases. But then, as a team, we all headed out to get actual TAVR training. And in addition to the educational components, it involved watching live cases and being involved in kind of asking questions and getting answers and being trained through the company. We actually used some models where we did it on these computerized models that would be very critical of every wrong move. So if you advanced the wire a little too far or didn't go far enough, it would be sure to dock you points, and you had to go through all those steps. Those are some of the ones I recall. Yeah, ones like a big chemo.
Well, a lot of the training that, I think, Amir and I, during interventional cardiology training, a lot of the wire skills and the techniques that you do for other procedures are relatively the same. What's different is the new technology that's now available. One of the exciting things about our field is that there's always new things coming out. The field of cardiology and cardiovascular surgery does not stay stagnant. There's always something new coming out every couple of years. So that's why I personally went into this field, because it was a very exciting thing. As far as the training is concerned, Blair and CJ took us to Houston. We trained at Houston Methodist for a couple of days.
Yeah, Medtronic has been very, very supportive in making sure that we've been as prepared as we could be for our first cases. In addition, we have proctors coming in for the first case. These are people that have done thousands. And, you know, we've been lucky to be able to pick their brains for every possible contingency. And it's just when you think that you know everything that could possibly go wrong, that something new goes wrong. And we've been fortunate enough that we've really been as prepared as we could be, and we've had excellent proctors, and you know, they don't come anymore. Our training wheels are off, but we have the resources through our colleagues to get help at any point in time.
Yeah, the proctors have been a big deal. We had folks that have done hundreds and some of them thousands of cases that were there literally in the cath lab with us at the time. Could have done it without them. And of course our team members, folks in the operating room, folks in the cath lab, they traveled and did special training above and beyond what they routinely do on a daily basis. They're really behind the scenes, and they're not up here at the table, but they've put a lot into this as well, and they've had extensive training as well, loading the valve on the delivery device and all the things, and then converting a cath lab into a kind of hybrid suite where we can do what is essentially a combination of a heart catheterization and an open heart operation in the same room with all the personnel that's there, anesthesia team, perfusion team, and so forth. It's a production. So all those people have done a lot of work to get this happening.
I would echo what Dr. England just said, which now that I'm thinking through the steps, it's been since a few months now, so you have to reflect on it, but the cath lab kept drilling through that, you know, having these runs where they would say, well, okay, how will it go when it goes smoothly? What are the steps? And then what if there's a problem? What if A happens or B happens? How do we convert to open procedures? Thank God we haven't had to do anything like that. But what if it happens, you know? And so there are a lot of steps, and I think it may seem like, oh, these four are sitting here, we must have some really technical prowess or something, but it's not like that. It's the team that makes it happen. You know, you're there, you're just doing your part, which may be the guy who's unwinding this or just getting the positioning just right, but there's so much more that involved all those steps of all those team members. And I think once you have that up and running, I mean, it's a wonderful thing that we're involved in now.
We had meetings when we really, the biggest limitation to us doing this was getting the proper CT scanning technology so that we could do the studies beforehand to plan the procedure. You have to have a really high-level CT scanner. You've heard we've got our 128 slice CT scanner that we've had since last fall. Before we had that, we just didn't have the equipment to do it. So the hospital administration really stepped up to the plate and got the CT scanner for us. And that's when we became really involved in moving forward with this technique. But we would meet weekly with lots of people, sometimes 20, 30 people would be involved in these meetings to plan this, planning how we were going to coordinate going for training, getting the patients ready, getting everything set up for all the steps. For example, the CT scanning is done differently for these patients, which we didn't have the CT scanner, we got that, but then you have to get the people that do the scans, trained how to do the scans for us. And then the radiologist did some stuff with reading the scans for us. And that's just one of the many steps. So there was a lot of things going on since the fall up until we started in February.
Any other questions?
As you mentioned, before the procedure being in Bay County, patients were having to travel hundreds of miles to receive the service. Just in your practices alone, can you give us an estimate on the number of patients that will now be able to receive this care in Bay County at Bay Medical Sacred Heart?
Yeah.
We're
Go ahead.
anticipating, we've been up to 15 now since February 1st. We're anticipating about 50 or 60 a year for the first year. The number will likely grow as we move forward, hopefully. That's 50 or 60 patients that either would have stayed in town, that may have just been managed conservatively with medicines and may not have done well at the 2-year mark, or patients that have had to travel to, let's say, Emory or in Atlanta, which is a big burden on the families sometimes as far as traveling all together, and God forbid a complication happens and they're longer than the 2 to 5 days that they would normally be here. So it is a great asset for the community to have Bay Medical support, get some technology in here to offer these to our patients.
I would even venture that it's probably more patients than we would even anticipate, because a lot of these patients don't ever even reach, well, forget Greg and Reed and I, but they may not even get to the cardiologist because they're seen by their family doctor. They're 89, 91, 92, 93. And of course, before, the only option we had was surgical aortic valve replacement. And God forbid, they send those patients to the surgeon. So they have already made a medical decision based on the technology from 10 years ago and the data from 10 years ago that the best way may be in these elderly patients that are very high risk for any kind of surgical procedure to treat them with medicine. And since they're not even going to consider an intervention, they may or may not send them to the cardiologist. So I think that we're seeing a lot of patients come out of the woodwork.
I would say, as a community, not just Bay County, but nationwide, we've done a great job of certain things like breast cancer awareness or heart attack symptoms. But valvular heart disease is one of those that's kind of not as much discussed. It's more of a chronic problem, and sometimes as the patients get older, they feel a little bit hopeless about it. And I have a lot of those patients in my own practice who now are considering this. And I think things like today, having this press release, having this technology at the hospital help to invest in the future here, and having the team that could do it, will start to raise the awareness. And I'm hoping that that becomes something where we're treating people so that they're not suffering all the time and just give up. I think it's a new thing. We actually have somebody who's 92 years old coming for the procedure. And that might sound crazy, but he still has a quality of life. He's still functioning and going to the store and having a social life, and he just can't breathe anymore. So we're bringing him, and I think he's going to do great. But that's now our opportunity to raise the awareness and to expand the service line that we provide our community.
That's awesome.
We were sending probably amongst us and the other cardiologists easily a patient a week. So we're like they said, 50 plus patients a year that would have to travel to Atlanta for their pre-op evaluation, another trip to actually have the procedure, and everything goes smoothly, and then another trip for their follow-up. That's a tremendous burden on these folks. Now they don't have to do that.
That's right.
Hey, Blair, CJ, what percentage of hospitals in the country are doing TAVR? Of all the hospitals, less than 10%?
Right now, there's just over 400, so whatever the total number of hospitals is, so it's not a huge percentage.
I think there's about 5,000 hospitals, so that'd be less than 10%.
Yeah.
So, if you think about that, less than 10% of hospitals in the country are actually able to have the infrastructure to do this type of procedure. And we're in little Panama City. We're not Atlanta, we're not Cleveland or Chicago. So it's a great investment for this community to have a hospital that has given us such support to move this forward in this community. I think it says a lot. Because if you think about less than 10% of the hospitals in the country that are doing this type of procedure, I think it's a big statement for this community.
All right, well, Dr. Patel, you're very humble, as are your associates. It's a small community in some respect, but we are blessed to have very well-trained, talented medical staff members and physicians on the medical staff that support these types of efforts in our community. I started by saying it was an exciting day for us, and it's a very exciting day for us, but not only for us, but for all of Bay County and our contiguous counties, because this truly is an advancement to an already advanced cardiac service line that we have and hold here at Bay Medical Center. I'm very proud to be able to make the announcement today. I'm very proud of our medical staff. This was their vision. Thank you, ladies and gentlemen, for that. Very proud of patient outcomes, and thank you folks very much for coming, being part of our day today. And I have a lot of pride for our future patients, knowing that this is truly a procedure that changes lives. And when Mrs. Vandenberg shared with me that she was almost 90 years old, I could not believe it. I'm not. What an amazing procedure. I'm proud for the future patients. This is something that I think for us really makes that statement that we wish to be a leader in cardiac care. We are a leader in cardiac care here at Bay Medical Center, and we have a great team of physicians and nurses and technicians that come together to take excellent care of patients every day. Thank you for coming today. Media, thank you for being with us. We'll stick around for a little while if you want to talk or get any interviews with the folks present in the room. And again, a great day for Bay, and thank you for being with us.
Jesse, good job.